facing a health condition, especially something involving your body's main artery, it can feel really daunting, a little scary even.
Absolutely.
And all the medical terms, they just add to the confusion, right?
Right.
So today we want to do a deep dive into something called descending thoracic aortic aneurysms, or DTAA,
Mm-hmm.
and also a modern treatment, thoracic endovascular aortic repair, or TEVAR.
Yeah, TEVAR.
Our goal here is really simple. Just cut through that jargon, give you the essential insights you need to feel, well, more confident talking with your healthcare team.
Exactly. Let's start with the basics. What is a descending thoracic aortic aneurysm?
Okay.
So imagine your aorta, that main artery, like a big garden hose running through your body.
Okay, like a hose.
A DTAA is basically a weak spot or like a bulge in the part of that hose that's in your chest.
I see.
And it's serious because, like a stretched out hose, it can get weaker over time and potentially it could rupture.
Rupture, wow, okay.
Yeah. But what's really crucial for you to know is that some big risk factors, things like uncontrolled high blood pressure and smoking, well, those are things you can influence.
Right. Things you can actually do something about.
Precisely. Managing them isn't just, good general advice. It's a powerful way to potentially slow down how fast that aneurysm grows and lower the risk of it rupturing. Gives you a bit more control.
That makes a lot of sense.
Yeah.
So if it's like this weak spot in the hose,
Yeah.
how do doctors fix it? Is it always like major open surgery?
Well, that used to be the main way, open chest surgery, big operation.
Yep.
But now that's where TEVAR comes in, Thoracic Endovascular Aortic Repair. It's really changed things.
TEVAR. Okay, how does that work?
It's minimally invasive. So think about fixing a leaky pipe, but doing it from the inside. You don't have to tear open the whole wall.
Oh, okay. That sounds much better.
It often is. The sources we looked at show, compared to the traditional open surgery, TEVAR usually means much lower rates of complications, shorter hospital stays.
Which is huge.
It really is. And better short-term survival rates, too. Shorter stays mean, faster recovery, getting back home sooner. So yeah, for many patients, TEVAR is now the preferred way to go.
So when is it actually recommended? Is it for everyone with a DTAA?
Good question. Not necessarily for everyone. It's generally considered in a few main scenarios. First, if the aneurysm is actually causing symptoms like pain.
Yeah.
Or if it's an emergency, like, sadly, if it has ruptured.
Right.
Second, even if there are no symptoms, TEVAR is often recommended if the aneurysm gets to a certain size. Usually around 5.5 centimeters, give or take.
5.5 centimeters, got it.
And also for some related conditions like an intramural hematoma that's bleeding inside the artery wall, or something called a penetrating aortic ulcer, especially if those are getting worse or causing persistent problems.
Okay, so once a DTAA is found, how do doctors actually plan the repair? You mentioned fixing it from the inside. That must need a really good map, right?
Yeah. Absolutely. That's where imaging is just critical. Before TEVAR, you'd get detailed scans, computed tomography, angiography, or CTA scans.
CTA scans.
Think of them like getting ultra-precise blueprints of your arteries. They look at the whole aorta, arteries in your head, neck, legs. It lets the team plan meticulously, choose the right size stent graft, everything.
Makes sense. Plan carefully.
But, and this is really important, the imaging after the procedure is just as vital.
So follow-up.
Yes. Regular CTA scans are usually recommended, typically at 1 month post-procedure, then 12 months, and after that, yearly. For life.
Really? For life? Wow.
Yeah, it's basically like essential long-term maintenance checks for the repair. We need to monitor it, make sure everything's okay, and catch any potential issues early, like something called an endoleak.
Endoleak, what's that?
That's where blood might still be leaking around the stent graft and getting into the original aneurysm sac. We need to know if that's happening.
I see. So the surveillance is key.
It really is. And during the procedure itself, the team uses lots of protective strategies, too. Things like carefully managing your blood pressure, trying to use less X-ray dye to protect your kidneys, and special techniques if arteries going to important places, like your left arm or your gut, need to be covered by the graft. These are like built-in safety measures, backup plans.
It sounds like TEVAR really is a significant step forward then.
Yeah.
A powerful, less invasive option for DTAA with some real benefits over the older surgeries.
Definitely. Big advantages in recovery and fewer complications for many.
And hopefully understanding all this helps you feel a bit more prepared, maybe less anxious.
Exactly. This knowledge really empowers you, doesn't it? It helps you have those important, informed conversations with your doctors.
Yeah.
So maybe something to think about after this deep dive. Don't hesitate to ask really specific questions.
Like what?
Like, okay, what is the exact size of my aneurysm? Or how does that size specifically factor into recommending TEVAR for me?
Good points.
And if you've had TEVAR, ask, what's my exact follow-up schedule? And what specific signs should I be watching out for that might mean there's an issue? Your doctors want you to ask these things. They're there to help you navigate this.